First, thanks for the invitation. I found Dr. Hassan's testimony, I think, to be extremely powerful. I think it does highlight a weakness that we have in our field as sleep specialists, and that sometimes I think we get too caught up in numbers rather than sometimes listening to the patient. I actually feel pretty blessed to be working in a health system in which there is the flexibility of being able to, make diagnoses even if the numbers don't completely fit, even, providing empiric, treatment for, diagnoses, for somebody who, I believe either has narcolepsy or idiopathic hypersomnia and so forth. So, a lot of these patients really need some, immediate relief. And, for a college student, who has finals and so forth, even delaying a couple of months, can very much be problematic. Part of that flexibility also includes the ability to introduce some kind of, fun little projects. I think we kind of describe this project as maybe kind of like a little fun, cute little project, where we introduced a sleep vital sign based on a simple 2-question survey for utilization in a primary care clinic. Has a little bit of background. We developed a sleep vital sign, 2 questions, with the goal of improving the recognition of patients with potential sleep disorders and to eventually track longitudinal sleep-related outcomes. So here are the 2 questions. Question 1, or sleep vital sign 1, is how many days a week are you not satisfied with your sleep? And question number 2 is how many days a week is sleepiness a problem, both of which are scored on a scale of 0 to 7. The idea here is that one question is more targeted towards sleep disruption and the sleep experience, and the other question is more targeted towards consequences of poor sleep, namely sleepiness. Here are study aims, the first of which was to essentially do something exploratory and see whether the sleep vital sign actually matched, the scores of other standardized or standard validated sleep surveys, namely the Stopping, which is a screening tool for obstructive sleep apnea, the Insomnia Severity Index as a measurement for insomnia severity, the Epworth Sleepiness Scale as a reflection of sleepiness, and the FOSQ-10 as a measurement of general sleep quality. Next, we wanted to evaluate the utility of the sleep vital sign in identifying patients with potential sleep disorders as a screening tool in the primary care setting. So we had, give or take about 1,000 patients, and I'll highlight some of the differences actually between men and women. That's you can see over, that's kind of highlighted by the blue arrows on the right side. Women have tended to have a higher sleep vital sign 1, which is a reflection of more sleep disruption or poor sleep experience, and their sleep latency was quite a bit higher. Give or take about 50 minutes as opposed to 30 minutes. Men, on the other hand, drink more caffeine, and as expected, the neck size and the Stopping scores were higher as well. So first, we wanted to take a look to see whether the sleep vital sign had a similar pattern and, with the Epworth Sleepiness Score. And what you can see here for both vital sign 1 and for vital sign 2, as the sleep vital sign score increases, the Epworth score increases as well. And so that we found that was a statistically significant pattern or relationship that we identified. Same thing for the Insomnia Severity Index. In fact, the pattern is probably a bit more pronounced. Same thing for the FOSQ-10 for both the sleep vital sign 1 and sleep vital sign 2. And also for the Stopping, at least as it related to sleep vital sign 2, which is the question related to sleepiness. So overall, what we found, we felt pretty confident that the sleep vital sign was measuring what we expected to measure, being able to identify potential, sleep disorders and sleep symptoms in people who truly are having some trouble with their sleep. So in regards to the part of the project as it relates to the implementation in a primary care setting as a screening tool, this was the protocol that we used. Step number 1, the medical assistant would collect the sleep vital sign in addition to the blood pressure, heart rate, etc. Step number 2, if either the sleep vital sign 1 or 2 was at least 4, meaning that they had problems at least 4 days or at least half the week, then we would proceed to step number 3. Step number 3, the medical assistant would provide an expanded questionnaire. A lot of what we were trying to do was to really simplify the process for the primary care clinic and the primary care physician. We know that the primary care clinics are overwhelmed. They have a lot of responsibility. A physician has 5, 10, maybe 20 minutes to assess a patient and then to manage them. And so we really wanted to streamline this for the primary care physician. And so the expanded questionnaire and the algorithm looks like this. Over on the left side, there is a series of 7 questions that are asked to the patient as it relates to whether they snore, whether they have problems falling asleep or staying asleep, whether they feel like they're not getting enough sleep, are they shift workers, do they have restless legs, and do they take any medications for sleep or for depression, and whether they doze off regularly in a way that impacts their ability to function during the daytime. Whether they answer yes or no to these 7 questions, the primary care physician can follow this algorithmic tree that you see on the right side that'll lead to a recommendation or various recommendations. For example, should the patient be referred to sleep medicine for possible sleep disorder breathing, or for insomnia, or for hypersomnia evaluation for a patient who we think might be at risk for narcolepsy or idiopathic hypersomnia. So we really tried to implement this as a way of truly simplifying this for the primary care physicians. And here are our results. Over on the left side here, on the left graph, and the leftmost side here where you see the SVS, half the patients were randomized to the sleep vital sign pathway. And you can see that 18% of them were identified to have a potential sleep disorder and referred to sleep medicine, versus only 2% of the patients that were randomized to usual care. What we also found that is really a critical result here is that of the 83 patients that were identified to have a potential sleep disorder and referred to sleep medicine, only 19 of them actually showed up to their sleep medicine appointment. And so one of our key conclusions from this study is that an effective screening tool cannot be limited to just identifying patients who have a potential sleep disorder. It has to be partnered with some type of engagement strategy, for the patient to really understand and to become engaged with following up with their sleep evaluation. So in conclusion, first, we successfully implemented a novel sleep vital sign, a 2-question survey in the primary care clinics. Number 2, we or applying the sleep vital sign increased the rate of identifying potential sleep disorders and increased the referral rate to sleep medicine clinics. Number 3, however, most patients did not keep their sleep clinic appointments, indicating that engaging patients and not merely identifying patients is critical for successful sleep disorder screening strategies. That's it for my presentation.